Good day. My name is Frank Peacock. I'm an emergency physician at Ben Taub, which is Houston's county hospital. I've been doing this about 40 years, so I've seen a few things. And then we're going to talk about acute intermittent porphyria. And I'm here with my friend, Dr. Eddy Lang. Eddy, I'm going to hand it over to you.
Thank you, Frank. Hello, everybody. My name is Eddy Lang, and I am an emergency doc and a professor in the Department of Emergency Medicine at the University of Calgary in Alberta, Canada. I don't have quite as many years under my belt, coming up on 34. Started when I was 16, in case anyone's doing the math and trying to guess my age. Um, just a little bit more about me and AIP. I've had the honor and privilege of doing some teaching on the topic. Even have had a few colleagues reach out to me and say that they were able to make a pickup based on some of the education that they had heard from me. And it's a fascinating topic. I'm glad to be here.
Well,
So,
Eddy, you want to start with how do we recognize this challenge?
yeah, exactly. I can take that, Frank, if you want. And yeah, it's AIP, so that's acute intermittent porphyria. It's a complex syndrome manifesting in a number of unusual ways, and it really requires a high level of awareness and index of suspicion to even think about it because it doesn't often present in the typical manner. So just, we'll go into some more depth here, I think, as our conversation goes along, but we can see the most well-described presentation is with severe abdominal pain, often intermittent bouts of abdominal pain. You can see pain in other areas, anxiety, depression, oddly. So you can also see neuropsychiatric manifestations of AIP attacks. And then the other interesting things that can happen with acute intermittent porphyria is that you can see autonomic dysregulation. So you can see peaks in blood pressure, heart rate abnormalities, muscle weakness, tingling, numbness, and other kinds of neurological sensations. And one of the key things to be aware of when you're taking the history on a patient with possible AIP is that they will report urine discoloration. Oftentimes, this is visible after being exposed to light. So, yeah, there's a couple of things to keep in mind if you're thinking acute intermittent porphyria that can also mimic other medical emergencies. And I think the key problem for emergency medicine is we're heavily reliant on imaging. So, sometimes going down the CT route is not going to help because there's actually no structural or visible abnormality on ultrasound or CT imaging of the abdomen that will point you in this direction. So, Frank, why don't you share your insights and your thoughts on what an emergency physician needs to keep top of mind to make this diagnosis?
Sure. I think you sort of covered it really well there. It's an abdominal pain disease that has all these other symptoms that do not fit in. One of the important parts is what you were talking about abdominal pain, and pain is what the patient tells you. They're in excruciating pain, they're in crying, but they don't really have tenderness. So when we think of abdominal pathology, you think of appendicitis, it's tender in the lower quadrant. You push on it and they don't like it. Gallbladder disease, it's tender in the right upper quadrant. But tender is what I elicit. And the strange thing here is this is pain out of proportion exam. And the only other thing I think of is ischemic bowel, which is the same story. They don't really have a focal tenderness. It's sort of just general pain. And that's positive on CT, whereas acute intermittent porphyria is not. And that's the sort of the killer here is that, as you said, we are reliant on imaging. I personally think we do too much, but we scan about everybody with abdominal pain. And that's one of the triggers here is that the CT is going to be negative. The pain of AIP is neurologic. It is not inflammation of some organ. And so you're going to get a CT, it's negative. And if you look at these patients' history, they frequently have multiple visits to the ER. And they may have 2 or 3 CTs, all are negative. And at some point, that in itself is a trigger. You have to say, well, if they keep having negative CTs, what is their disease? And that's where you have to put it together. There are not a lot of stuff that will give you abdominal pain and neurologic symptoms. And the neurologic symptoms of porphyria can go all the way through seizures. And so if they're having excruciating abdominal pain and weakness, this can go to bulbar paralysis. They can, and when it's really bad, they can have respiratory failure, and you have to tube them. So this combination of seemingly not converse pathology is the trigger to knowing that it's AIP. When I was on surgery as an intern, I was working with a surgeon, and he made me take the urine from the patient every morning and put it on the windowsill. And then I had to come back in the afternoon and look at it. Now, I will tell you, I never caught an AIP patient doing this, but it's the perfect way because if you have AIP, the urine will turn red or purple in the sunlight. And it just takes a little bit. And that's one of the almost diagnostic triggers. So if the patient tells you those stories, that's helpful. And if they don't, that's one of the tests you can do to make the determination. But the key is making one diagnosis. You have all these symptoms that don't seemingly fit together. You can say, well, maybe this young, and they're usually female. The reason this is triggered by hormones, it's one of the reasons you can be triggered, and we'll go through all the triggers in a minute. But so it's usually female, younger. They're not old people because this is a genetic disease. They tend to present at least earlier in life, not when they're 80, but when they're 20s or 30s or something of that nature. They can present as kids as well. But if they come in and you're going, I'm looking at this lady, she's got belly pain and she's got this neurologic weakness. It's MS and an appendicitis. It's like, yeah, that's possible, but it's really rare. I looked up the numbers on this. There in the United States, there are a couple 100,000 patients who have acute intermittent porphyria. And if you do the math on that, that is 0.06%. That's 6 in 10,000. Rare by any measure. AIP, I looked at that. You get 300,000 a year in the U.S. That comes out to be 0.1% or 1 in 1,000. And MS is there's a million people walking around with MS in the U.S. and out of the 300 million Americans, that's 0.3%. So if I'm looking at somebody going, wow, they've got MS and an AIP, well, that's 3 in a million that will have both, whereas only 6 in 10,000 have acute intermittent porphyria. Go with a higher number there. Trying to explain belly pain and neurologic abnormalities, the law of parsimony is everything should be as most simple. It's, Occam's razor, cut it to its finest. And if you're coming up with 2 diagnoses for their 2 symptoms, the odds are you're wrong. And so go with the one. And in this case, it'd be porphyria. And that's the key is now emergency docs aren't going to make this diagnosis often because there are no tests that we can do really quickly in the emergency department. I looked at my department. I don't even have the ability to order porphyrobilinogen level in my department. It's a send out. So I'll order it and it'll go they'll pee in a bottle and it'll go off to the lab and come back tomorrow, which means I can do nothing. But if I order it, I pull the trigger to get the patient the right diagnosis. Some of these people are miserable. If you look at their histories, they've had a year or 2 of symptoms that were awful and nobody did anything. They'd come to the ER, they'd get some pain medicine, they'd get discharged home with a non-diagnosis. If you can pull the trigger on that, you might pick up a case and change their life. The important parts here, the things that are happening are not reversible. So if you get a neurologic injury from your AIP, that is not going to be fixable. You can then treat their disease; they won't get any more. So it's really important at some point to step up and get this. When you order the urine test, it has to go into a bottle, and because it's light sensitive, it needs to be wrapped in aluminum foil so that when it gets to the lab, the products that they're trying to measure are still there because they degrade. So that's sort of the trick on that. So the tests we usually do are CT scans, and that's appropriate. When a patient comes in the emergency department, I tell my residents all the time, if you're going to miss something, make it rare. Don't miss something common. So when somebody comes in with belly pain, we're going to get a CAT scan, and that is appropriate. Looking for all the things that will be positive on a CAT scan. Abdominal pain is the number 1 presentation in most emergency department, and when it's not abdominal pain number 1, it's number 2. So, and these are fatal events, so you have to find those. Don't miss something common. But when you're done with that, and you found out, they don't have an aortic dissection, and they don't have appendicitis, and they're not having an ectopic pregnancy, and all the things we worry about, think about these other things that put all their symptoms together in a single diagnosis. And that's getting the urine sample and sending it off. So, Eddie, it's important to know a trigger attack. What are some of the common triggers?
Yeah, for sure. I mean, I think you've captured the diagnostic conundrum with this condition really well. And the way I see this is almost when most of these patients have had multiple emergency visits before they're finally diagnosed. And if you take the analogy of a safety error or a quality lapse, that classic Swiss cheese model, a number of missed things line up, and people fall through the cracks and end up having recurrent emergency visits and repeat unnecessary investigations. So the key thing here is to think about other things that might trigger or might be signs that this is actually not a chronic abdominal pain patient, not someone with opioid use disorder and who is often, unfortunately, labeled as a drug seeker, but where there's actually an organic problem going on. So keep an eye out on the sodium. There could be often a low sodium in the picture. You can, as I mentioned, the autonomic dysfunction, you'll even see elevated heart rates once the pain is under control, but also pay careful attention to the triggers that may have brought the patient in. So particularly in the luteal phase or the second half of the menstrual cycle, the balance of hormones is such that it can often trigger AIP. The other thing is that there are a long list of medications that can be associated with triggering AIP attacks. And also someone who is in a catabolic state. So frequently, and I guess this is maybe has a similarity to DKA, a gastroenteritis or someone who's been fasting or not eating well for a day or two or longer puts themselves at risk and may not even realize that this is what is the trigger for their attacks. And of course, there's going to be a lot of overlap with other conditions like just simple gastroenteritis if in fact they come in with abdominal pain and vomiting. So these are the things to kind of keep an eye out for. And as Frank mentioned, I don't think our role is necessarily to make the diagnosis in the emergency department, but it's at least to consider it. And we used to make fun of our internal medicine colleagues and say, they're ordering a serum rhubarb on the patient because they're looking for that rare bird. When an emergency doctors are saying, if it don't look for zebras if it looks and sounds and acts like a horse. But this is that one exception where you can really rise above and become a bit of a diagnostic hero. And remember, often you need help making this diagnosis. So that might involve convincing an admitting service that, yes, true, this patient has been in an emergency department a couple of times, but there's something that's not fitting. It's not a classic patient with opioid use disorder or chronic neurological or functional causes of abdominal pain, and they merit further investigation, including the possibility of them having AIP and needing to come in for what is usually a 24-hour assay and a urine porphyrobilinogen collection. So not only that, but also I think in speaking to our gastroenterologists, they may often be involved in the care of these patients. They're already on their second or third CT, and you're bringing the gastroenterologist in ostensibly for an endoscopy, an upper endoscopy usually, and, just drop that hint. Say, I'm really not sure what's going on with this patient. I think we need an endoscopy to make sure we don't have an acute gastritis that we're missing. But I've also sent off a urinary porphyrobilinogen, which needs follow-up because it could represent acute intermittent porphyria. So, Frank, is that your experience? Is that the way to finally get these patients diagnosed is to clue into the triggers and just raise your level of awareness to the point where you're going to go through your list of maybe even uncommonly ordered tests and find that one urine porphyrobilinogen sampling that the nurses, of course, are going to raise their eyebrows. They're going to say, "What? Aluminum foil?" And that's often the way to get to these rare diagnoses.
Yeah, I mean that's the only way to pull the trigger, and we won't see the end result. We will. You can follow them up tomorrow, but yeah, you got to think about it. Well, once you've
So,
done that, emergency doc's job is disposition. We have to decide inpatient, outpatient, what happens, observation, whatever it is, and we really only have two options, either in or out. the, uh, the challenge of admitting somebody is you sort of have to know what goes on, and so I wanted to talk about that just a little bit on the inpatient side, and what that is. So the way porphyria works is you have a enzyme allosynthetase that makes it's the synthetic trigger of this whole pathway. There are 8 enzymes that are needed. Succinyl-CoA and glycine are combined by this enzyme, and then it goes down the pathway. And you don't need to know all these enzymes, but each enzyme deficit creates another disease in the porphyria. There are 8 kinds of porphyria, and of that, these products are toxic, and that's what causes you a problem. So inhibiting the creation of toxic products is the game. And the way you do that is you give them heme. It is given IV. It's sort of caustic. It fries up your veins. But that's not going to happen in the ER, and that's not going to happen at home. So a patient who has a symptom beyond just abdominal pain is probably coming in, and if it's anything significant at all, and these people get bad neuro complications, they get seizures, and they get all sorts of emotional problems associated with it, anxiety and hallucinations and that sort of thing can happen. That's going to trigger an ICU admission because those people can end up going badly quickly. Their nerves are getting eaten by all these toxic metabolic products. Most commonly, it's porphyrin downstream, but there's a whole bunch of others, but they're all toxic. They eat your nerves, and if that's occurring, they're going to be in the ICU. What we can do in the emergency department, in either as a stall technique while we're trying to get them admitted, or in somebody who's really mild, is we can give them glucose. And the reason is that insulin is an inhibitor of that first enzyme, allosynthetase. And so give them some glucose. And if they are better enough to go home, they can take oral, they're not throwing up, their pain's under control, they can maybe go home. But if they have any other symptoms beyond just this abdominal pain, you're sort of stuck here on getting that patient in. And so then that gets them in the hospital, and you're making an ICU or not decision. So these patients are a problem. A lot of the drugs we use are a problem. And so there's websites on the internet that you can go to and find out the safe drugs. But the drugs I like to use, I can't. I like to use ketamine. Nope, that triggers this sort of stuff. And sulfa for urinary tract infection, that's a no. The seizure medicines we like, Dilantin is a no. You can use, there are certain drugs in all the categories that you can sort out and use, but you have to be really careful or you make these people worse. So it's having the suspicion so you don't make them worse, and admitting the sick ones to the hospital and maybe the ICU. So if you're down this road, a lot of these people get hospitalized. The pain management is a huge problem. Eddie, you want to comment on that a bit?
yeah, for sure. We have limited options, especially in someone who's having nausea and vomiting. So although there are some risks, I think you can still proceed with the common things that we use for control of nausea and vomiting and abdominal pain. So I don't think we have short-acting opioids like hydromorphone or fentanyl that are strictly contraindicated. I mean, you can start with small doses and see how they do. I think the most important thing is to give the body enough calories to get them over the hump. So often just a rehydrating solution where you're including at least 10% glucose is an important option. Now, what's unique in my situation is that we also take care of AIP patients who are already diagnosed, and they're currently under the care of a geneticist or a nephrologist in most cases, and they come to emergency department with what we call a pre-established care plan. And on that care plan is a document that they present to the triage nurses. It's usually signed by the patient and their specialist, and and it provides a clear protocol for their own individual management, whether it be to give them a dose of heme or start a D10 glucose solution. And it also will often contain the reminders of what are the things to avoid. So, while the focus of our conversation, Frank, is to really help elevate the understanding and awareness of AIP, I think the other piece of the puzzle is that often these patients are somewhat stigmatized in that, they have this history of having come to the emergency department on a regular basis. But once they're known to be AIP patients, hopefully they'll have a specialist follow up, and they'll be able to communicate, because they're not always in a condition, either from severe abdominal pain or from the neuropsychiatric manifestations, to really explain what's going on. So, yeah, those I think are the main things. Um, Frank, did you cover everything you wanted to talk about with regards to what the emergency doctor who may not initially be all that familiar with AIP needs to do to make this rare diagnosis?
Well, so I wanted to throw in one other thing on the treatment side. Hyponatremia, abdominal pain, neurosymptoms, it's sort of like this triad of things that don't normally travel together. And so if you're going to treat these patients and their sodium's a little bit low, they are high risk for SIADH. And so you want to give them sugar, but you don't want to give them just D10 because you're giving them more free water, and that's not going to help things go the right way. And they can have sodiums that go really low, and then they seize from their hyponatremia. So you have to be really careful with these folks. But all you do is take normal saline and stick some sugar in there. And there's formulas on the internet to figure out that. But you're trying to create a 10% solution, but it's in saline, so that you're not making their hyponatremia worse. The other weird thing is this cerebral salt wasting syndrome. And when I've read about this, it's not really clear what the causality is. It's associated with porphyria. But the way I think of it, and one of the theories on why it occurs, is because of the neurologic effects, they have B-type natriuretic peptide release. And that creates water wasting. So you're going to pee, it's a natriuretic peptide, so you're going to pee salt water. And so they come in, and these two extremes, they can either be hyponatremic for either one of these. With SIADH, they're volume normal or overloaded. And with CSW, cerebral salt wasting, they're volume depleted. And that's an important determination, because if you're volume overloaded, giving a lot more volume is not great. And if you're volume depleted, not giving more volume is not great. So you have to make a decision, and that's done on volume status. You just have to be conscious of what you're doing. Is I'm thinking about this patient's volume, and I'm going to do the right thing on them. If it's SIADH, you can also give tolvaptan. I don't know a lot of ER docs who are allowed to use that. It's usually the nephrologists are involved in the case, and that's sort of, I think, what you were talking about. Is there's a whole team of folks who are involved in these people. So the liver is the source, the greatest source of problems here. So there's hepatologists involved. There's nephrologists because of the renal issues and the hyponatremia. There's neurologists because these people have seizures. And so if you can figure all this together and get the team, that's pretty cool. And they then become the long-term management folks of this, because you need a whole team to manage these people. They have so many systems that are critical. And I didn't even talk about the skin things. We don't see this much in the ER, but they all have various kinds, not all, but there's several kinds of the porphyrias that have rashes associated with them. They're very sun sensitive, and they get these blisters all over them. And so the dermatologists end up getting in. And then with this complicated mess, they show up back in the ER for their 14th visit. And if they have a team, it really helps a lot. Eddie, is there anything I missed on this?
Well, I think you've captured it perfectly, Frank. Of course, being a disorder of heme metabolism, we also see some of these patients followed by hematology. But I think at the end of the day, let's recall that there are certain unique features to AIP which should raise a purple flag. And I say that intentionally because of the purple nature of the urine that's described, that occurs only during the attack and not necessarily when the patient is well. In fact, porphyria has its roots in the Greek word for purple, if I'm not mistaken. Not that I speak Greek, but this is what I've heard through the grapevine. So, yeah, I think this is an opportunity to really make a difference in a patient's life. We all know individuals who have chronic recurrent abdominal pain that are multifactorial. Most of them don't have AIP, but one of them will, and it will take that extra level of awareness and consciousness and thinking outside the box rather than groaning and rolling your eyes when you pick up a chart of an abdominal pain patient who's now back for their fourth time.
He's
Take a
he's
fresh
back.
start. take a fresh look and say, hey, you know what? Maybe there's something else going on, and this is an opportunity for me maybe possibly become a diagnostic hero because you will go down in the Hall of Fame in your emergency department if you are the one who can pick this up. So that's pretty much it from my point. I don't know, Frank, if you had any other closing thoughts on our discussion.
Yeah, I think that's a good point. You see these people all the time who come in with belly pain and vomiting. In my department, they're called cannabinoid hyperemesis syndrome. Their CAT scans are negative and they're thrown out. As soon as you can make them quit throwing up, then they're out the door and they go home on Zofran. This is over and over. And even if they deny smoking marijuana and their drug screens are negative, they get labeled with this. And I have this feeling somewhat guiltily that I may have been part of that once or twice because we see these people all the time. This is another part of the differential that you should consider. It's an easy thing to do a porphobilinogen test and go ahead and send them home anyway. They were good enough to go home. But I think that you're right. You could be a diagnostic hero if you're the guy who fixes this person, and you are fixing them because now they've got things to do. They can follow up with other physicians as an outpatient and decrease their common presentations to the emergency department. I think I'm going to start wrapping it up a little bit. I think we do not always identify rare diagnoses. I think we see them at the same frequency as every other doctor. But our whole practice is on excluding the emergency that will kill them in the short term. And that is still our job. That doesn't go away if you think about porphyria. You still need to make sure they don't have something. You send home an ectopic pregnancy, and that's on you. So we still have our focus on the emergency, scary diagnoses. But if you can, as you're thinking about managing this patient, once you've ruled out the life threats, then you're looking at the longer term life threats, which this is certainly one. So if we can break that cycle, we have really done a job for our patient. So, Eddie, you have any
One,
closing thoughts?
just one final thought going forward. Um, we're all on an electronic health record, has advantages and disadvantages, but it would be great. I think it would be a service to the AIP community if we could once see the day when the computer and AI can recognize a pattern of emergency visits that could be a suggestive of AIP. And I know we all hate those pop-ups and those warnings and those alerts, but for a patient who's now on their fourth or fifth emergency visit, it'd be great if the EHR could gently suggest to us, have you thought of AIP in this situation? If you have, just click here and we'll get a urinary porphyrobilinogen on them. And so I think our female and male emergency doctor colleagues both can make a huge difference in the lives of these rare but at-risk patients if we pay attention to those kinds of things.
Outstanding. Okay, I think we're done here. Eddie, it's been great talking with you this morning.
As well, Frank, it's been a pleasure.